Hello, I am Vignesh Kailasam, editor of the Journal of the Indian Orthodontic Society, and I am going to talk to you, my friends, about the Steiner's cephalometric analysis. We know that a cephalometric parameter or a cephalometric analysis is a supplemental diagnostic aid, and today we are going to focus on the most commonly used cephalometric analysis, that is the Steiner's analysis. So the objectives at the end of this masterclass should be to know the values of each parameter of Steiner's analysis and understand the clinical significance when this parameter is either normal or increased or decreased as the case may be. In today's specific class, we are going to focus only on the skeletal parameters, while we know that the Steiner's analysis is a composite analysis of skeletal, dental and soft tissue parameters. We should also be able to clinically explain when the values are normal, increased or decreased. So the Steiner's cephalometric analysis, or any cephalometric analysis for that matter, is a part of a diagnostic aid which is classified into either essential, as the name indicates it's compulsory, or supplemental, as the term indicates it is used when we do not get conclusive evidence with the essential diagnostic aids. So a cephalogram or a cephalometric term is a Latin term, ceph meaning head and metric meaning measurements. So we know that the face can appear different, and most importantly, every face is beautiful. Make no mistake about that, every face is beautiful. So we are not going to quantify the beauty of the face, but we are just going to look into the aesthetics of the face. Any cephalometric parameter, which is a radiographic parameter, can evaluate the underlying bone when we call it the skeletal parameter, or it can look at the superficial soft tissue which envelops or covers the bone, in which case it is called the soft tissue parameters. So it can have a skeletal parameter which is the underlying bone. In our case, in our specialty, it is the maxilla, mandible and the cranium as a reference plane, or it can involve the soft tissue. It is critical that we differentiate between a skeletal parameter and a soft tissue parameter, because it may match, more importantly it may not match. And obviously, as an orthodontist, as a clinician, we are going to treat the soft tissues rather than the hard tissues. So if there is a mismatch between the soft tissues and the hard tissues, we should be looking at the soft tissues, but at the same time understand and explain why there is a mismatch. As I mentioned, cephalometrics is coming from the word ceph, which means head, and metrics, which means measurement. So in simple terms, it is a study of the head measurements, and it should be emphasized that it is a supplemental diagnostic aid and is not meant to replace a clinical examination. So the clinical examination is critical and is an essential diagnostic aid, and the cephalogram or the cephalometric parameter is just used to substantiate, is just used to prove what is assumed or diagnosed at a clinical chairside level. So a chairside examination should not be replaced by a cephalometric evaluation, and in case there is a controversy or there is a mismatch between the clinical view and the cephalometric view, the importance should always be given to the clinical view. A cephalogram is different from a natural head view of the face because it is standardized and taken with a very special equipment called a cephalostat, and is taken as a lateral cephalogram. So what are the uses of a cephalogram? So we saw that it can be used to assess the soft tissue, it can be used to assess the hard tissue, and from a clinician point of view, it gives us what is the diagnostic problem, it gives us what are the changes which takes place with growth, and it can also tell us what are the changes which took place with treatment in either the dental, which is tooth based, skeletal, which is the bone based, or the soft tissue, which is basically the soft tissue which covers the hard tissue. So we saw that it can predict growth. So you can see that when you take a photo of a young individual like this, we can use the cephalogram to predict the growth, not necessarily as they show in the movies, but we can predict the growth in terms of how much the cranial base will grow and how much the maxilla and mandible will grow. I am sure all these pictures which you see in the slide, who are all famous cinema artists, you can predict how they will look at the age of 18 or 20 or 22 as the case may be with cephalometrics. So, all these famous stars, if you can take a cephalogram at the age of 7 or 8, it will be very easy to predict the growth and development of these individuals. So, coming to a clinical orthodontics, we can use this to see what were the changes which were brought about by either natural growth, abnormal growth, or the treatment related changes. For this, we use what is known as a superimposition. That is, we take two cephalograms taken at different time points and we put it on stable structures, stable meaning structures which do not change, and then we see the changes. For example, here we can see by superimposing on the maxillary plane or the mandibular plane what are the changes which have been brought about in the tooth. So, here you can see the maxillary incisor and the mandibular incisor showing changes. So, this is the second most important use of a cephalogram, that is, we can bring about or we can showcase to the patient with evidence what were the changes which were brought about either with treatment or with growth. It is very important as a clinician you understand that a lateral cephalogram is different from a lateral view of the skull, which is taken by a medical professional in contrast to an orthodontic professional. There are three major differences. That is, the first difference is that a lateral cephalogram is standardized. It is taken with an equipment which is specially designed and it is called a cephalostat, and all these measurements are standardized as I mentioned, with the most important standardization being the source of X-ray to the mid-sagittal plane of the patient is 5 feet. So, the important advantage of taking it with a standardized machine is that these values will be same, will be exactly ditto if it is taken in Madras, in Mesopotamia, or in Madrid. So, the standardized values will not change depending on where you take it. So, this is the picture of a cephalostat, and since it is standardized, like I told you, from the mid-sagittal plane of the patient to the X-ray source, all machines are standardized at 5 feet. So, at a postgraduate level, you should know that there will be some machine to machine variations, but in general the magnification will be similar and therefore will not change with a natural view of the skull. So, what are the parameters? This we have studied in undergraduate orthodontics. The distance from the X-ray source to the patient or the mid-sagittal plane of the patient should be 5 feet. The distance from the patient to the film should be 15 centimeters. It should be preferable that we have a high speed film. In these days of digital technology, these do not matter. The exposure time should be minimal because we want reduced radiation, and there should be complete clarity with the hard and soft tissues. When the position of the head should be standardized, that is, the patient should be looking up front into a mirror, and this is called the natural head position, where the Frankfurt horizontal plane is parallel to the floor. The simplest method of achieving this is to keep a mirror in front of the patient and ask the patient to look into the mirror so that the vision coincides. So, then we assume that the patient is in natural head position. The occlusion, that is, can be either at rest or the teeth in complete centric occlusion or in initial contact depending on our case requirements. A standardized lateral cephalogram is always taken at rest position. So, this is something which I want you to understand. We take the first important objective is we do not take the frontal view, which is what we see in the photo, in the center of the photo, but we take a lateral view. This is a fundamental diagnostic understanding that we treat the patient as we see from the sides. But however, the patient always looks at himself or herself from a frontal view, and this is one of the biggest disadvantages of a lateral cephalogram. The patient looks at the face from a frontal view, whereas we take all parameters in a lateral view to treat the patient. I told you about the standardization. So, you can see these 4 pictures when it is a photograph. For obvious ethical reasons, we cannot take a radiograph, but I hope this photograph will make you understand the importance of standardization. So, the fundamental difference here is when you see that blue line which depicts, for example, the mandibular length, you can see that the length of the mandible differs depending upon the magnification of the facial photograph. So, you can see that the length of the mandible can be 5 times or even 10 times depending on the magnification. So, this is an inherent problem with a photograph because there is no standardization. So when a medical professional takes a lateral view of the skull, you will have this problem because of lack of standardization, and the source of the X-ray can be kept at different points, leading to a magnification of the lateral view of the skull. This is completely eliminated in a lateral cephalogram because all over the world in a lateral cephalogram the distance is standardized to 5 feet, and therefore all these parameters will eliminate the scope of magnification. At a postgraduate level, we have to understand that there will be machine to machine variation, and this is given a leeway of 5 to 7% to a max of 10% as the literature shows us. The take home point from this slide is that a natural or a lateral view of the skull is different from a lateral cephalogram, and I hope I have made the point loud and clear. First requirement of a lateral cephalogram is to do multiple analysis, and the Steener's analysis is the most commonly used cephalometric parameter to assess the jaw discrepancy. So for these we have to identify landmarks, and these landmarks, as the name in English, as the word in English indicates, are reference structures or points, and these do not change, and these have been defined nationally and internationally as points which are defined as the same all over the world. Based on these points, we can either have an angular analysis or a linear analysis. As the term indicates, angular analysis indicates based on angles, whereas linear analysis is based on a minimum of 2 points and is in either millimeters or centimeters. Another variation of the linear analysis is what is based on a ratio based or a proportionate analysis. So we can have proportionate values, we can have linear values, or we can have angular values. So this is a picture of a lateral cephalogram, and the first thing which we do is put the cross marks. These cross marks are used in previous years because when we used to use a tracing sheet, we don't want the tracing sheet to change over time. But with the advent of computers, we do the tracing on a computer, and so these cross marks may not be required. We do it in previous years, in my times, because when we use a cephalometric tracing sheet, we don't want the tracing sheet to slide over the lateral cephalogram. The important rule in putting these cross marks or these points are that it should be on a very clear area, that is, it should be on the white area, and normally we put 2 on the head region, the forehead region, and 1 in the cervical vertebra region, preferably not masking the relevant cervical vertebra, which is C3 or C4 as the case may be. So once we put these crosshairs or the landmarks, we are pretty sure that the acetate tracing sheet will not slide, and in case it slides, you can always reorient it back to this original position. Then we go to landmark identification. Each particular software or each particular cephalometric analysis has multiple parameters or landmarks, and we are going to today focus on the Steener's cephalometric analysis. There are multiple definitions, and most of it are going to be extremely familiar because of repetition. The nasion is the most anterior point on the frontonasal suture. Similarly, you have sella, which is the geometric center of the pituitary fossa. These 2 points are in the reference plane or in the cranial base and these are called reference points simply because after the age of 6 or 7, if you remember Kamman's growth curves and the cephalocaudal gradient of growth, you realize that these 2 points will not change after time, and that the adult size is reached by the age of 6 or 7. So nasion and sella, which are there in the upper third of the face, do not show great changes with growth after the age of 6, and as the name indicates, a reference plane is a plane which does not change. Then we go to other parameters which can change either with treatment or with growth, and these are point A, which represents the maxilla, the point B, which represents the mandible, or the gonion and the gnathion, which are multiple points on the mandible. Sella, the most important point, is the midpoint of the pituitary fossa and the geometric center, and it houses the pituitary gland. So we zoom it and we can see a horseshoe shaped structure, and the geometric center of this point is defined as sella. We use the alphabet S to define what is sella. Going into the anatomy, we can see it clearly on the bone, the horseshoe shaped structure, and we identify it 2-dimensionally on a lateral cephalogram. The second point which has to be identified is the nasion or the most anterior point on the frontonasal suture. So, we zoom it and we can see the triangular shaped bone, and the most anterior point is the frontonasal suture depicted by nasion or the point N. So, we have covered S and N, and a line connecting these 2 points is called the SN plane, which is the reference plane for the Steiner's cephalometric analysis. So, this nasion is critical because from a postgraduate point of view, any anteroposterior movement of the nasion will definitely affect the position of the maxilla and mandible. And what is more important as a postgraduate you have to understand is even a vertical positioning of the maxilla of the nasion can affect the position or the relative position of the maxilla or the mandible. The third point, which depicts or represents the maxilla in the Steiner's cephalometric analysis, is point A, which is the most posterior midline point in the concavity between the anterior nasal spine and the prosteon. So, this point we refer to as point A, and Steiner's cephalometric analysis, point A represents the maxilla. So, if the point A is slightly forward, we call the maxilla prognathic, and if the point A is backward, we call the maxilla retrognathic. So, the important message is that the maxilla is represented by point A. Similarly, the case in the mandible. So, here we take 2 points, and here we take 2 points. The one is the cemento-enamel junction of the lower incisor, and the second point is the pogonion, and the most posterior midline point in this concavity between the infradentale and the pogonion is referred to as point B, and point B, just like point A, represents the mandible. So, if the point B is slightly behind, we refer to the mandible as retrognathic, and if the point B is slightly forward, we call the mandible as prognathic. So, you can see a image of the skull, and we can see whether the mandible is prognathic or retrognathic. Even though we use only one point for the maxilla, for the mandible there are multiple such points, and the one which represents the mandible is called point B. In addition, we have what is known as a gonion. So, gonion is the point on the curvature of the angle of the mandible, and that is referred to as gonion. We represent it by the alphabets G-O. Once we construct the gonion, then we go to a point on the chin, and the chin is defined by 3 points. So, in addition to point B, which defines the mandible, the chin is defined by 3 points, that is the pogonion, gnathion and the menton. So, the difference between these 3 points is they are defining the chin and not necessarily the mandible. So, pogonion is the most anterior point, menton is the most inferior anterior point, and gnathion is taken as the midpoint between the pogonion and the menton. So, when we zoom and when we see the chin, the gnathion is observed by taking the midpoint between the pogonion and the menton points. So, these 3 points refer to the chin. So, now my friends, we have constructed all the landmarks. So, now our job is to connect these points. So, we know that cella and nasion is a reference plane. What do we mean by a reference plane? That these points do not change over time. So, when we connect cella nasion to the point of interest, that is a maxilla, that is the A point, we get an angle, and this angle is called SNA, and when if we connect SN to B, we get an angle called SNB. So, in a class 1 profile, that is when the maxilla and mandible are orthognathic, the SNA value is 82 degrees plus or minus 2 degrees, whereas SNB, which represents the mandible, is 80 degrees plus or minus 2 degrees. As I indicated in my previous class, anything greater than 80 degrees for the SNB indicates that the mandible is prognathic, and anything greater than 82 for SNA indicates that the maxilla is prognathic. The vice versa is also true, that anything less than 82 for the maxilla, that is SNA, or anything less than 80 for SNB, that is the mandible, is defined as a retrognathic maxilla or a retrognathic mandible. Then we go to an assessment of the maxillomandibular relationship. Now we have defined the maxilla, we have defined the mandible as either orthognathic, prognathic or retrognathic. Now we want to know the relationship between the maxilla and the mandible. For that, there are multiple cephalometric parameters, and I would refer you to the article by Shobha Madam in the Journal of the Indian Orthodontic Society, where they have spoken about 21 such parameters. In the Steiner's analysis, it is A and B, or what is known as the angle A and B. So we join the A point, the N point and the B point, and A and B is also equivalent mathematically to the difference between SNA and SNB. So A and B, a normal value of 2 degrees indicates a class 1 profile. Anything between 2 to 4 is class 1. Anything greater than 4 in the positive direction is class 2, and anything less than 2 or a negative value indicates a class 3 malocclusion. So that is how we draw the A and B, and we get a normal value of 2 degrees, or anything more indicating a class 2 profile, anything less indicating a class 3 profile. The fourth parameter in your Steiner's cephalometric analysis is your mandibular plane angle, and for the mandibular plane angle, which is a cephalometric definition, we use the SN plane as the reference plane, and we use the gonion to gnathion connecting points as representative of the mandibular plane. Gonion is a posterior point and the gnathion is an anterior point, and when we connect these two planes or these two lines, they meet at a certain point, and this angle is called the mandibular plane angle. Steiner ascribes a normal value of 32 degrees, and anything more indicates that the mandible is rotating in a clockwise pattern, or what is referred to as a vertical growth pattern, or anything less indicates less than 32 indicates that the mandible is growing in an anti-clockwise pattern, or what is known as a horizontal growth pattern. So this is the fourth parameter, otherwise referred to as GOGN to SN, or the mandibular plane angle as defined by Steiner. The final parameter in all your cephalometric parameters, in all your skeletal parameters, is the occlusal plane to SN. So the occlusal plane is drawn by one connecting the SN plane to the occlusal plane, and this is referred to as the cant of the occlusal plane. The cant of the occlusal plane is an important diagnostic feature in that it shows that it in the patient's original form is the most stable pattern, and the cant of the occlusal plane varies between 10 to 14 degrees and should be altered with care. So summarizing the Steiner's skeletal parameters, we saw what is SNA, that is a line or the angle connecting sella, nasion and point A. SNB, sella, nasion and point B. A and B, that is point A, nasion and point B, the occlusal plane angle and the mandibular plane angle. So a couple of questions for you, my dear friends, and I am going to show you a few pictures. So here you can see that this patient is an adult. By looking at him itself, you can see that he is an adult, and you will realize that there is not much growth left, or there is virtually zero growth left. So the cephalogram cannot be used for assessing growth. But if you take a lateral cephalogram of this patient, based on your chair side examination, you should be able to come to some kind of a conclusion that he has got a convexity of the profile, he has definitely got a class 2 profile, and you would like to know whether the maxilla is prognathic or the mandible is retrognathic. You must come to all these questions or all these conclusions based on your clinical examination. This is the intraoral pattern which confirms the class 2 dental and skeletal parameters. So when we take a lateral cephalogram of this patient and we trace this, it should substantiate our clinical examination. Like I told you, the first thing which we do is we draw the SN plane, and that is drawn between sella and nasion. Then we draw SNA angle, or what is known as the sella, nasion and point A, and sella, nasion, point B. Those who are prudent and those who are sharp will notice that I have not put the crosshairs. So if you notice it and if you correct me, I am really and truly happy. After this, I draw the dental parameters which we have not covered in this class, and then we complete our Steiner's skeletal and dental parameters, and we come to the conclusion that the SNA is 82, bang on 82 for this patient. So we conclude that the maxilla is orthognathic. We can see that the normal value of the SNB is 80, and we can see for this patient it is 74. So we can say that the mandible is deficient correct? And then we see that the A and B, a normative value of 2 to 4 degrees indicates class 1, and here we got 8 degrees, which we can say is a very severe form of class 2, and we also go to the dental parameters. So, we can safely diagnose with the aid of our clinical examination and with the Steiner cephalometric evaluation that this patient is an adult patient with no growth left. He has got a class 2 malocclusion with an orthognathic maxilla and a retrognathic mandible. So, obviously the treatment plan is going to be, since he has no growth, to surgically advance the mandible, and this is what we have done. So, his pre-treatment pictures, his post-treatment pictures, and the cephalogram, which indicates a plate there which shows that the mandible has been surgically advanced. So, you can see that the cephalogram has been used to identify the malocclusion, more importantly to conclusively prove what is a clinical suspicion that it was a retrognathic mandible, and since there was no growth left, we proceeded with surgical advancement of the mandible, and you can see the plates there on both the lateral cephalogram and the orthopanthomogram. So, I have just proved to you with a case where we can identify a class 2 malocclusion. You can also use the cephalogram for identifying a class 1 or a class 3 malocclusion. A class 1 is where the maxilla and mandible are orthognathic, and a class 3 is where the maxilla is either retrognathic or the mandible being prognathic. So, my dear friends, I hope this session on Steiner's cephalometric analysis would be useful for you in your academic endeavors, and if you have any doubts, please feel free to contact me, Vignesh, at either via email, which will be provided to you in every masterclass, or through Sree Balaji Dental College, and I will be glad to assist you in any of your academic doubts. Thank you for the opportunity and best wishes for all your future endeavors. Thank you.